Hi everyone, I'm Dr. Anu and I'm here to make pediatrics simplified for you. In the part 1 video, we were discussing about dengue fever and its pathogenesis. And today we'll be looking at the part 2 video where we are going to discuss about the clinical features and the lab investigation for dengue fever. Let's get started. So a quick recap of the previous session. So in the previous part 1, we saw the vectors and the pathogenesis of dengue viral infection. So we knew that dengue virus is caused by Aedes aegypti mosquito and the pathogenesis is two things. One is leaky pipe and confused antibody. To know more detail of this concept of leaky pipes and the confused antibodies, please watch the part 1 video. So because of this, there will be excessive damage to the endothelial glycocalyx and there will be leakage of the plasma from the intravascular to the extravascular space, and the clinical feature and the further complications of dengue is related to this. So let's look at the clinical features of dengue viral fever. So coming to the clinical manifestation, the clinical description of dengue fever includes acute febrile illness that lasts for 2 to 7 days duration with two or more of the following. So it can be headache, retroorbital pain, myalgia, arthralgia, rash, hemorrhagic manifestation, thrombocytopenia or leukopenia, and warning signs and symptoms. In the upcoming slides, we'll learn about the warning signs and symptoms. So coming to the case definition of dengue fever. So you call it as a probable case of dengue fever when a case that is compatible with the clinical description, that is fever with two of the following symptoms during a outbreak. So during an outbreak, if a person has these features, that you consider it as a probable case of dengue fever. Or if there is a non-ELISA based NS1 or IgM positive lab investigation, then you call it as a probable dengue fever. A confirmed case of dengue fever is when a case compatible with the clinical description that we mentioned, along with that, either of the following, that is isolation of the dengue virus from the viral culture, demonstration of IgM NS1 by ELISA method, demonstration of IgG four-fold increase 2 weeks after the illness, demonstration of NS1 antibody antigen with the ELISA method, or the detection of viral nucleic acid by the PCR reaction. Coming to the clinical phase of dengue infection, we know that dengue fever has three clinical phases. One is the febrile phase, second is the critical phase, and third is the recovery phase or the convalescent phase. So febrile phase, as you know, is the phase where there is fever, and critical phase, as it says, this is the phase when the most complications of the dengue will occur. Then comes the recovery phase where the person will eventually recover and come back to the normal state. So this is a graph that depicts the three phases of dengue viral infection. This is a very important must-know graph for all the medical students. So let's divide this graph into 4 parts regarding the temperature, clinical issues, lab changes, and the virology. So coming to this graph, you see in the febrile phase, the fever goes up. So only there is fever in the febrile phase, then the fever touches the baseline. So fever is seen during febrile phase. Coming to the clinical issue, in the febrile phase, there will be some dehydration, but there is no third space leaking. Coming to the critical phase, there will be excess of third space leaking causing edema. There will be shock, there will be bleeding manifestation, and it can even lead to organ impairment. Slowly, once the dengue fever recovery happens, all the extravascular fluid will come back to the intravascular compartment. So there will be reabsorption and fluid overload in the third phase. Coming to the laboratory changes, first there will be hemoconcentration in the critical phase along with thrombocytopenia in the critical phase. So during the febrile phase, all parameters are normal. At the end of febrile phase, your platelet starts to fall and your PCV starts to rise. And then in the convalescent phase, the platelet will gradually improve back to normal. and the hemoconcentration will reduce. Coming to the virology or the serology, so we know that NS1 is a nucleic acid antigen. So this NS1 will be positive in the initial viremic phase, followed by IgM in the critical phase, and then the IgG will slowly increase. So IgG becomes fourfold increase in the recovery phase. So let's look everything in detail. The febrile phase, there will be high-grade biphasic fever lasting for 2 to 7 days, and the clinical features include headache, vomiting, flushing, myalgia, arthalgia, and macular rash. Then comes minor bleeding manifestation where there will be skin and mucosal bleeding. There will be less common hematemesis, melena, or heavy menstrual bleeding, and you also look for petechial rashes and bruising. So you can perform a tourniquet test so to see whether it is a dengue related thrombocytopenia related bleeding. So coming to the critical phase, this is called the leakage phase. So in this phase it begins 2 or 3rd or 4th day of fever and can last up to 48 hours. It is characterized by vasculopathy, coagulopathy. It leads to plasma leak, hemoconcentration, bleeding, leading to organ dysfunction. So this is the most critical phase in dengue. We have to be very much careful in handling this phase because the patient will have shock. If you keep giving more fluids, the patient will have fluid overload in the convalescent phase. So there should be judicial fluid administration. However, in dengue critical phase, a lot of patients will present with shock, so we will have to give a higher amount of fluid to maintain the intravascular volume. So we will study about the fluid management of dengue in the next part. So now we will look at the further clinical features. So what do you call a dengue with warning signs? What are these warning signs? So warning signs are the ones which should alarm the medical practitioner to admit the patient as IP and to give the fluid management. So you call it warning sign when there is persistent vomiting, abdomen pain, lethargy, behavioral changes, bleeding manifestations, clinical fluid accumulation in the form of ascites or pleural effusion, enlarged liver of more than 2 centimeter, and lab findings of progressive increase in the hemoconcentration with rapid reduction in the platelet. So any of these persistent vomiting, abdomen distension, thrombocytopenia, hemoconcentration, hepatomegaly, bleeding manifestation, all these should alarm the practitioner to admit the patient. Coming to the convalescent phase, this is a phase where the extra fluid loss owing to capillary leakage will start coming to the intravascular fluid, and the patient's signs and symptoms will improve and patient will develop a convalescent rash. This is called Isles of White in Sea of Red. So the patient will have erythematous eruption with sparing areas of normal skin. So if fluid replacement is not carefully optimized, then patient will develop pulmonary edema. So coming to the overview of what we learned so far, dengue virus infection. So they'll have clinical manifestation which includes symptoms like fever, rash, headache, orbital pain, myalgia, arthalgia. They can have warning signs like recurrent vomiting, abdomen pain, and altered sensorium. Hemorrhagic symptoms like petechiae, purpura, ecchymosis, epistaxis can happen. The signs include hepatomegaly with tenderness, pleural effusion, ascites, and a positive tourniquet test. Because of plasma leakage, they can have pleural effusion, ascites, hypoproteinemia, hypovolemia, and shock. And the lab features include hemoconcentration, that is more than 20% rise from the baseline, thrombocytopenia with platelet less than 1 lakh, leukopenia with counts less than 4,000, coagulopathy with INR and APTT elevated, and transaminitis. So you would see CBC and LFT and PTINR, APTT. In this you can see that PCB is high, total counts is low, platelet is low, SGOT-PT is high, INR and APTT is elevated. Coming to the radiological investigation, you can do a chest X-ray to find out pleural effusion and pulmonary edema. Ultrasound will show A calculus cholecystitis. So coming to the clinical case classification of dengue. So dengue viral infection can be asymptomatic or symptomatic. Based on the nutritional status and immunity system of the patient, it can become even asymptomatic. If it becomes symptomatic, you classify it as A, B, and C. A is dengue without warning sign, B is dengue with warning signs and comorbidity, and C is severe dengue. In A, you can again classify into A1 and A2 as with risk factor, without risk factor. So if it is dengue without warning signs, you do a home-based or OPD-based management. So here the patient will have only fever, normal platelet count without complication and no evidence of capillary leak. And if the patient has comorbidity, you just call it as A2. Then coming to dengue with warning signs and comorbidities. So we studied the warning signs. So this will require close monitoring and possibly hospitalization. And the comorbidities include infants, old age, diabetes, hypertension, pregnancy, coronary artery disease, hemoglobinopathies, and patients who are on steroids. Coming to severe dengue, we label it as C as C1, C2, and C3. C1 is shock, C2 is bleeding, and C3 is organ involvement, which will require tertiary care and ICU admission. So let's see what tourniquet test is. So tourniquet test is performed by inflating a BP cuff cut to a point midway between systole and diastole for 5 minutes. So if the patient's BP is 120 by 100, you keep the BP cuff at 110, keep it for 5 minutes, and what do you see? You take a 1-inch square. If you see more than 10 petechial spots, then the tourniquet test is positive. So in severe dengue, this will give a definite positive of more than 20 petechiae. So that means the coagulopathy and the thrombocytopenia is so severe to cause more than 20 petechiae, and the test may be negative or mildly positive during shock. So coming to the lab diagnosis, so we know ELISA-based NS1 antigen test is there. It is used in viremic stage. IgM capture enzyme-linked immunosorbent assay can be used in your critical phase. Isolation of dengue virus, why it is not seen in most of the places? Because the sample should be taken in the first 5 days of illness. Without a delay, it should be processed. And the specimens that can be used are acute phase serum, washed buffy coat from the patient, autopsy tissue from fatal cases like the lymph node or liver or spleen tissue or the thymus, and this culture can also be taken from mosquitoes. Coming to lab diagnosis, the other methods are PCR, IgG ELISA, and hemagglutination inhibition, complement fixation, and neutralization test. And we also have rapid diagnostic tests. Though these are very easily available, the reliability of the test is poor. So we will discuss the management of dengue fever. I have put it as a different part video because it is little more complicated to understand, and I have to teach you little elaborate for you to manage the patients efficiently. Please watch the part 3 video for fluid management of dengue fever. So please give a like if you had enjoyed watching this video, and comment if you want to know more on other infectious diseases. And also if you have any doubt regarding this topic, you can mention that in the comment section. Share it with your friends and keep learning.